might not be as familiar with Alzheimer's disease, I'm just going to quickly kind of hit some highlights. So this might be an orientation to Alzheimer's disease for some people or a reorientation to Alzheimer's disease for others. But just to make sure we're all on the same page with the terms that I'm using, when I say, when I'm talking about Alzheimer's disease and dementia today, when I use the word dementia, I'm talking about a clinical syndrome. So I'm not speaking to the etiology, the cause, or the pathology of the problem. I am just speaking to the clinical syndrome of cognitive impairment, functional impairment. But if I'm talking about Alzheimer's disease, I'm specifically talking about a particular type of disease or pathology that causes dementia. So this is just an overview that dementia is the umbrella term when we're talking about clinical syndromes. And then all the little raindrops on the bottom are all different ways in which somebody can have dementia. Alzheimer's disease being the most common, one of them. In terms of pathology of Alzheimer's disease, typically what we're talking about is, oops, I had animations, but I don't. We're talking about amyloid plaque, beta amyloid, neurofibrillary tangles or tau, and neurodegeneration. So ATN, amyloid, tau, neurodegeneration. So this is the framework that we use for a biological diagnosis of Alzheimer's disease. When we're talking about diagnosing the pathology is the ATN framework. There are many different ways in which we can measure amyloid, tau, and neurodegeneration, but these are the ways in which, or this is the framework with which we use to come to a diagnosis of the etiology of a person's dementia. So these are many different ways in which we can measure ATN pathology. We can do it through neuroimaging, various neuroimaging methods. We can look at cerebrospinal fluid, and more recently, even clinically, we can start looking at plasma or blood biomarkers for biomarkers of Alzheimer's disease. I only bring this up because this will be relevant later on in the talk when we're talking about clinical cases that have been part of LEADS and sort of the different measures that we used in order to make a diagnosis of Alzheimer's. But back to syndrome, we talked a little bit about pathology, but when we're talking about dementia, what are we actually talking about? When we're talking about dementia that is due to Alzheimer's disease, typically it starts with a memory impairment, right? That is usually the telltale sign or something that gets us concerned that somebody might have Alzheimer's disease. So if they're starting to have memory impairment, that gradually progresses to cognitive impairment in other domains as well. Initially, when someone is experiencing a neurodegenerative disease like Alzheimer's, it's obviously going to impact their independence in day-to-day life, starting with complex activities, and then getting worse over time such that it then impacts basic activities of daily living. It's almost always accompanied by some kind of neuropsychiatric symptom, and there's a lot of variability in terms of the prominence of those neuropsychiatric symptoms, so depression, anxiety, agitation, things like that. And it typically has a symptom onset after the age of 65, with age being the biggest risk factor for developing Alzheimer's disease. The problem is that not all presentations of dementia due to Alzheimer's disease are typical. So if we look at, for example, that typically dementia, there's a symptom onset after the age of 65. Well, it's not the case for early onset Alzheimer's disease. So these are individuals who develop symptom onset before the age of 65, usually between the ages of 40 and 64. There's approximately 28,000 people in Canada who have a young onset dementia diagnosis. So this is all type dementia. This is not just Alzheimer's disease. And about a third of those individuals have Alzheimer's disease. But there's a projected 187% increase in all-cause young onset dementia by 2050 onset. And when I'm talking about this includes people who have genetic predispositions. So there are certain genes that we know are associated with development of dementia. They run in families, varying levels of permanence, but we're also talking about sporadic. So people who don't have a genetic mutation that causes a dementia, these are people who are less likely to be identified. So in terms of early onset Alzheimer's disease, these individuals often face misdiagnosis or several years delay in diagnosis because people are not expecting somebody who is 48 years old to have a neurodegenerative disease. There is an increased financial, care partner, and societal burden for these individuals. You can imagine that somebody who is in sort of the prime earning years of their life, oftentimes people have children, oftentimes they might even be primary care partners for an aging parent or something like that, contributing to communities, contributing to religious affiliation, communities. There's a lot going on. And so a diagnosis at this time can be particularly devastating. The symptoms also tend to be more severe, both cognitively and neuropsychiatrically, in early onset Alzheimer's disease compared to what we would call late onset AD. So people who are diagnosed after the age of 65. So this is a more aggressive disease and tends to increase in severity a lot quicker. And then we look at, typically, we think of dementia due to Alzheimer's disease being starting with a memory impairment. But again, that's typical, but it's not always the case. Many people, a larger proportion than I think we previously appreciated, don't start with a memory impairment. They start with some other cognitive impairment or even perhaps behavioral or personality changes as their first symptom of having Alzheimer's disease. So it is also the case that in early onset Alzheimer's disease, individuals are even more likely than late onset AD to present with these atypical features. So you can imagine the compounded issue of people aren't expecting somebody who's young to have dementia or neurodegenerative disease. And on top of that, their neurodegenerative disease doesn't present the typical way that it's supposed to. So again, leads to a lot of, or can lead to a lot of misdiagnosis and delayed diagnosis. When evaluating for early onset AD, particularly in these non-amnestic or non-memory predominant phenotypes, we really do a lot of relying on imaging biomarkers, the CSF biomarkers, and now more likely plasma fluid biomarkers to identify whether there is an actual Alzheimer's pathology there that might be causing the person's impairment. In addition, neuropsych assessment tends to be, and now this is not just a plug for myself and my job, I guess, but neuropsych assessment can be particularly important in this situation for actually identifying cognitive impairment in these individuals, because oftentimes they or their family members have cognitive concerns, but they're not necessarily presenting as cognitively impaired to their GP, their family doctor, or their neurologist potentially. And these neuropsych assessments can be particularly helpful for kind of looking at the fine-grained differences in cognitive abilities across different domains. So as I was saying, there is pretty minimal understanding of these kind of, what happens with treatment in early onset AD, but even what are our clinical markers and biomarkers in early onset AD. The understanding of what this looks like in early onset AD is, there is research out there, but definitely not to the extent of like late onset Alzheimer's disease. And so we have a lot of our data or a lot of our information and is based on small samples of people with early onset AD. There's some exciting stuff that has been happening, I think anyways, is with LEADS, which is a huge observational study of sporadic early onset AD. There's also the Clinical Research Center for Dementia in South Korea that has a lot of people with early onset AD as well, and they're collaborating with US researchers. They have a lot of genetic data as well that is great. And then there's the DIAN study, which is the dominantly inherited Alzheimer's network, which focuses more on those genetic familial versions of early onset AD, like the APP and presenilin 1 and 2s. So LEADS is different than that because it focuses on the sporadic. It doesn't include people who have a genetic predisposition or a genetic familial mutation for early onset AD. So what LEADS is, the PI is Liana Apostolova. She is at Indiana University School of Medicine. And I am so grateful to her that she was willing to take me on and mentor me and bring me into LEADS when I started there in January of 2020, which was an interesting time to start a job. So LEADS is a huge, like I said, a huge study. I think it's like a $45 million NIH and Alzheimer's Association study, funded study. 18 US sites and 5 international sites, including South America and Europe. Maybe we'll get one in Canada, I don't know. But it's an, like I said, it's an observational study looking at the clinical and biomarker indicators of early onset AD for better diagnosis, as well as to provide a foundation to explore outcome or optimal outcomes for clinical trials in early onset AD. So we know, like, what should we be measuring? What are the actual useful markers that we need to be measuring when we start doing clinical trials in early onset AD? So just briefly, this is a 5-year study. So these individuals are being followed for 5 years. They get multiple assessments, clinical, cognitive, all sorts of imaging, biomarkers. Lumbar puncture is optional. They don't have to do a lumbar puncture to be part of the study, but the rest of it is required. So every year they're coming in and getting these assessments, as well as a lot of the neuroimaging that's done. Now you'll see on here that, oh yeah, oh, it doesn't work. It only works down here. It does not work on the screen. So early onset AD is the green circle. Early onset non-AD is the blue diamond. Those are individuals who, after doing their imaging and biomarkers, are amyloid negative. So they're not people, they might have a syndrome that looks like Alzheimer's disease, but they don't actually have Alzheimer's disease. So also interested in looking at those folks, and syndromically they look similar, but pathologically they are the same. So currently there are a lot of people in the study. We have all of the cognitively normal individuals, about 400, almost 80%, something 90% of the early onset AD folks. And then the 200 for the non-AD folks is just sort of a maximum. We're not necessarily trying to get a certain number. It's just sort of a maximum number is 200 that can participate. So lots of really awesome, great data there. And like I said, I'm continuing to collaborate with the team here, or team there, on a lot of the cognitive and clinical assessments, but also some of the plasma biomarkers as well. Okay. So I'm going to shift into talking about case examples that come from the LEAD study, about case examples about these atypical Alzheimer's presentations. So this information comes from a publication that myself and Dr. Apostolova did in 2022 for AAN Continuum, where we kind of outlined the clinical presentation of various phenotypes. Before I move on to that, was any questions about the LEADS study itself? Okay, cool. All right. Well, you can't ask any more questions about LEADS. Okay, so I have 5 cases. We will see if I get through a few of them. I probably won't do all of them, but I'll try and get through a few of them. So the first person is a 55-year-old male with 20 years of education. He was presenting in clinic for difficulties with language and memory over the past 18 months, and he had been diagnosed by his family doctor with stress and anxiety, causing these problems with language and memory. So his coworkers had noticed, upon kind of having the evaluation, found out his coworkers had first noticed the difficulty. He was having trouble following directions, performing his duties. And again, him and his spouse were just sort of like, this is probably just stress that's going on. It's getting in my way. But the difficulties progressed, and he was terminated after a poor evaluation. This was a job that he had had for almost 20 years. So this is not a new job. He had additional problems, including difficulty producing accurate speech sounds. He had trouble finding words, and he had difficulty with comprehension, so understanding what people were saying to him. He had to ask people to repeat themselves, and he often misunderstood when he was reading written forms. He didn't really understand what it was that he was reading, and he often let his sentences just sort of trail off, seemingly because he couldn't find the words he needed to express himself. He was otherwise independent in his activities of daily living, but he needed some assistance with managing finances because of his difficulty with forms. And he needed reminders for taking medications and managing his schedule and stuff. And he had stopped using the telephone because it was just too hard for him to understand what people were saying, but also express himself over the phone without the benefit of kind of face-to-face. When he had a full workup with a neurologist and a neuropsych assessment, what was determined was family expressed some concerns about some mild depression because he seemed a little apathetic. During the interviews that he had, again, that frequent reminding and sort of reorienting and rewording because he was having trouble understanding what was being said. His neurological exam was mostly normal, except for the speech issues that he was having in terms of word finding, but also some using a lot of filler words like thing and that versus specific words for things. He was talking around words, so circumlocutions, and he made a lot of phonemic and semantic paraphasias. So using the kind of wrong word, but one that is sort of similar to what you'd be looking for, but also producing just the wrong word that kind of sounds like the right word that you would have wanted to get. On neuropsych testing, the language impairment came out for sure. He was severely anomic. So when we asked him to name things, he had trouble naming what the items were. He could describe them, but he couldn't name them. 29 out of 60 on a test called the Boston Naming Test is incredibly low, very, very low. He also had problems repeating sentences, but his grammar, his syntax, and his semantic information was relatively spared. He was mildly dysexecutive, so had problems with planning and multitasking, organizing, shifting, that kind of thing. And had some problems with verbal working memory, but his visual spatial abilities were pretty intact. So when we look at his imaging, he had an MRI that showed more prominent left compared to right parasylvian atrophy. That kind of, as you can, I can't see it, but you can see here, it extended into the temporal lobe on the left-hand side. A little bit on the right, but not much. When we look at his PET imaging for amyloid, it was consistent with diffuse binding of amyloid. But his tau PET was a little bit more discerning in terms of where tau was binding, which was consistent with where the atrophy was on the MRI, which is that sort of predominant left parasylvian intertemporal lobe region. But it also included a little bit of posterior medial-frontal gyrus and posterior cingulate, which is pretty typical of Alzheimer's disease. His CSF, just a lot of numbers, but really the only one you pay attention to is this one. The amyloid tau index, if it's below 0.8, it means Alzheimer's disease, or Alzheimer's disease is diagnosed. So his PET imaging was consistent with his CSF, and he was diagnosed with something called logopenic variant primary progressive aphasia. So this is the language phenotype of Alzheimer's disease. So this is when a person with Alzheimer's disease presents with a predominant language impairment, not a predominant memory impairment. And it presents just like what we saw with this individual, poor naming, poor working memory, poor repetition of sentences, difficulties with circumlocution and talking around words, and interestingly, reading irregular words. Actually, I think that's wrong. It's not reading irregular words. It's reading non-words because it's a phonemic error. So it's non-words and you ask the person to pronounce it as if it's a real word and they make errors with it. So I will have to change that on my slide. Generally speaking, their motor speech and their grammar is spared, less of an issue. They have no problem with object knowledge. Again, in the object naming task, he's able to describe what the object was, but couldn't name it. And the language impairment has to be the predominant reason why somebody is having impairment in their daily life to be diagnosed with the dementia of the logopenic type. So about 50 to 75% of people with logopenic variant PPA are found to have AD as the cause of that syndrome. But again, it's not a one-to-one pathology to syndrome. So you can see here, anywhere between 25 and 50% are going to have a different pathology that looks like this syndrome. Case B is a 56-year-old cisgender female with 16 years of education who presented with vision and navigation difficulties that began 2 years earlier and progressively worsened, but nobody was able to give her an answer of why she was having these difficulties. So she said that she initially would notice difficulties with depth perception. So she was falling, for example, when going downstairs because she couldn't judge the distance of the steps and the stairs. She also wasn't seeing objects that were right in front of her. So her phone would be right here and she would be looking at it and she could not see it. So not surprisingly, you would think I have a vision problem, and she went to have a number of different eye appointments and evaluations. All of them were normal. Within the first year after her symptoms, she got lost going to familiar places, so going to her doctor's office. When she was driving at one point, she just kind of drifted and hit a guardrail. And her family reported that when she went to grab things, that she would misreach. So she would kind of do this to get her phone or that, until she finally was able to kind of land on the object she was looking for. Instrumental and basic activities of daily living were, according to her, generally intact, except for the driving issues that she was having. And she needed some occasional assistance with dressing because she was having difficulty sort of figuring out how to dress herself, like where the holes were and how to put her arm through and things like that. A lot of information here, but really what I want to just draw your attention to is on neuropsych testing, there is a severe visual spatial perception problem and with constructional impairments. So she was asked to draw the Ray complex figure. Are you guys familiar with this? Some people are, yeah, okay. All too familiar, like, no! Please, no, don't do it. This is what she drew. So this is what we call sort of an exploded copy. This is a non-integrated figure in any way. So you can see that she's capturing some details, but the details are not integrated in any way. Yeah.
Is this from memory or is this while looking?
No, this is while looking at it. This is while looking at it. This is what she drew. The different colors are just because we give a different color pencil with different times. So we can kind of keep track the order in which people drew things. So that is irrelevant in this case, but yeah, she had she was not able to integrate the details in any way, shape, or form. Makes you wonder what she sees when she's driving, right? Like, very curious. Yeah.
Angelina, does she think they're the same?
I mean, she said, yeah, I'm done. And I'm like, okay, was there anything on here that, you want to change? No. I'm like, okay. Yeah. And sometimes it's not a complete lack of recognition for everyone, because some people are like, I know this is not right, but they have no idea how to fix it. Like even if you give them a blank piece of paper and that you start again, they still can't do it.
You saw two designs like that were different, obviously, but related. Would she think they look the same, or?
So I would argue probably there's a good possibility, depending on the level of detail on it, she might not notice if they're the same, or she might not be able to accurately say or reliably say whether they were the same or different, I would argue, because she's having perception issues as well. It's not just an inability to construct, but she was also having issues with actual perception, like identifying objects and things like that she was struggling with. I think that was feel like there's something else I wanted to mention with that one, but yeah, at the end of the, regardless, the visual spatial perception and construction impairment was the predominant impairment that she was showing. She also had a severe visual memory impairment, but again, that's likely a result of having severe visual construction impairment. Because her verbal memory was not as impaired. She also demonstrated some mild executive dysfunction, some trouble with calculations, and anomia. So in terms of her MRI showing atrophy, there's profound temporal-parietal occipital atrophy. Her amyloid PET was positive for Alzheimer's pathology, and her tau again was fairly consistent with what the MRI showed, as well as some additional bilateral involvement of the frontal lobes. Her CSF was positive for Alzheimer's disease, and she was diagnosed with posterior cortical atrophy due to Alzheimer's disease. So this is the visual spatial phenotype, PCA. There are different kinds depending on where the pathology starts. You can have slightly different presentations, but the key feature of this is that there is a strong and prominent and often incredibly impairing visual spatial impairment right from the get-go. KC was a 35-year-old cisgender man who was an Afghanistan veteran with 14 years of education. And he was presenting at the clinic with 2 years post-symptom onset. His family was requesting a second opinion because he had been diagnosed with a psychiatric illness. So his spouse initially noticed some personality changes about the 2 years prior. The spouse noted that he reported that he was confused about their relationship, and he had started to pursue another woman, which his spouse said was extremely out of character for him. He also presented with apathy, flat affect, and lack of empathy, and some problems with judgment. Over the course of the 2 years, the symptoms had progressed. They didn't stay stable. He developed some obsessions. So he became obsessed with Publishers Clearinghouse. Do you guys know that? It's like, yeah, oh yeah, he was into it. Which are kind of like, I mean, they're kind of scams is my kind of understanding of it. And he had spent around $50,000 on those. He also was like very obsessive about seatbelts and like buckling in his seatbelt. I think about a year after symptom onset, he was unable to hold a job. He was an electrical apprentice, and he had failed multiple times at different jobs for various reasons. He was also experiencing problems with math, spelling, word finding, articulation, processing speed, multitasking, and memory. So this was not just some personality changes at this 2-year point. He developed hoarding and didn't really know when to stop eating. If you put food in front of him, he would just eat everything that was right there. So his wife had to really limit his diet and kind of monitor him. So it's a very, not because he was unsatiable, but it was a bit of a, like a stimulus bound behavior. It was there. So he had to do, like, he was responding to what was in his environment rather than what was internally needed by him. He occasionally had some visual hallucinations that were not distressing. Mostly they were people, and sometimes he would have a conversation with them. And he had a delusion that a toy robot dog was real. This was his 2-year-old son's dog, and was very upset, would get very upset the dog wasn't eating. Yes, so there was also, I think they had to buy a couple of different dogs because of like trying to water the dog and like all sorts of things. Yeah. I do want to draw attention this time to the MoCA. So this is a cognitive screener that I'm sure some of you are familiar with. Extremely low. I've never seen a score 3 out of 30. He was basically just not able to engage with the cognitive screener. Not surprisingly, neuropsych testing, even though typically in a clinical setting, we would never do neuropsych testing with somebody who had a cognitive screening score of 3 on the MoCA. But for the study we did, he was globally cognitively impaired, but his visual spatial skills were relatively spared. And he had a normal neurologic exam, except for some brief reflexes with lower extremities worse than upper extremities. So his MRI showed global atrophy. At this point, mild to moderate hippocampal atrophy, and FGG PET, so looking at hypometabolism, showed frontal, anterior, middle temporal, and bilateral parietal hypometabolism as well. Interestingly, relative preservation of the posterior cingulate, probably because the posteriorly hadn't been as affected at this point. So his amyloid PET, consistent with AD, and tau PET, again, was consistent with where the atrophy was well, his atrophy was pretty global, but he had a classic sort of that temporal parietal frontal involvement. ATI was less than 0.8, and he was diagnosed with behavioral syndrome due to AD, and he was eventually pathologically confirmed at autopsy. So this is one of two frontal phenotypes of Alzheimer's disease. This is the behavioral syndrome. So it starts with personality changes, behavioral symptoms, and progresses usually into dysexecutive issues and then kind of progresses to include other areas of cognitive impairment. So he was originally diagnosed with depression and psychosis. And he had seen psychiatry, he had seen his family doctor over the course, I think, about a year and a half or so, and was diagnosed with depression and psychosis. But I think my understanding from the spouse was this was sort of like, we don't know what's going on, but we have to give a diagnosis of something. So I think it sounded like his doctors were aware that this was not just depression and psychosis, but they didn't know what else it could be. But what it ended up being was Alzheimer's disease. Remember, this person is 35 years old, like super, super young. Very, very unexpected. I think at one point they thought maybe it's PTSD from being in Afghanistan or something like that. And just as a final note here, about 10 to 40% of people with a incorrectly spelled behavioral syndrome that might look like behavioral variant frontal temporal dementia, another type of neurodegenerative disease, a tauopathy. These individuals actually have Alzheimer's disease. They don't have the frontal temporal lobar degeneration, but can be very confusing as well. Even if you get to the correct diagnosis of this is a dementia, more often than not, you're going to get behavioral variant FTD before you get behavioral syndrome due to AD. Case D, 57-year-old cisgender man with 12 years of education. He was also presenting for a second opinion because he had been diagnosed with a functional neurological disorder 9 months ago after about a year of symptoms or so. So his partner was concerned about his cognitive changes, but he didn't think there was anything wrong. His partner reported that he couldn't follow conversations or his own train of thought. He was rigid and very concrete or literal in his thought processes, and it led him to make some inappropriate or odd choices and decisions. He was distractible. He had some additional cognitive issues like finding words. He was a little clumsy. He was a little forgetful. Behaviorally, his partner described some problems with empathy, a little bit of compulsive behavior, anxiety, apathy, these sort of like neuropsychiatric, but it wasn't an overly prominent part of his profile. And these cognitive problems have resulted in job loss for him. So again, he was diagnosed with a functional neurological disorder. Is everyone familiar with what functional or conversion disorder? Is that, yeah. So it's basically when someone presents with a neurological problem, but we can't find a neurological cause for that problem. We oftentimes think it might be related to psychological causes, but that's not the only cause of functional neurological disorder. So in terms of his neurological exam, totally normal. But when we did laureate hand testing sequences, so you do like fist, edge, palm, I can't remember exactly. Anyways, he was unable to do the sequencing, the motor sequencing of his hand when we did that. He also wasn't able to perform any even simple calculations like simple subtraction, simple addition, simple multiplication. He had multi-domain cognitive impairment, but it was most prominent in working memory and executive function. He had less severe impairments in language and memory, and his visual spatial perception was intact. The MRI showed atrophy of the medial and lateral frontal lobes, perhaps not surprisingly, given his working memory and executive functioning difficulties and those sort of mild personality or behavioral changes. And there was a relative sparing of the medial temporal lobe. Amyloid imaging was diffusely positive for AD, tau binding, AD-like pattern, but again, consistent with the MRI, showed relatively less binding in that medial temporal lobe that we see with more of a typical Alzheimer's disease presentation with memory impairment. Declined to do CSF, so we don't have that. And he was diagnosed with dysexecutive syndrome due to AD. So this is the second frontal phenotype of AD, which is the dysexecutive. So this one is, if you can think of it as the two frontal, is one's behavioral predominant, one's cognitive predominant. So oftentimes these individuals have what appears to be exceptional cognitive impairment relative to their age and other things that they're kind of engaged in their day-to-day lives. So much so that people, medical providers might say, like, it's impossible that you're this impaired. That doesn't make any sense, especially given your age. It's not typically associated with profound personality changes like the first phenotype, first frontal phenotype is. And again, this diagnosis is fairly high. There was a paper that when I was on postdoc, that one of the neurology fellows, behavioral neurology fellows wrote, basically defining this dysexecutive syndrome due to AD. So the last case is a 42-year-old cisgender man with 12 years of education. He was presenting in clinic with 3 years of progressive cognitive and motor decline that had recently impacted his ability to continue working in his job in heavy machinery. So his spouse thought that maybe memory impairment was kind of the first symptom, but definitely things had progressed since that time. He had become confused about directions and not just getting in the car and going somewhere, but he couldn't find his way to the barn, which was on his property. He would get turned around and lost in a familiar grocery store, one that he would go to all the time. He was also clumsy and was falling more frequently. Additional symptoms including dressing apraxia, so that's the difficulty kind of orienting shirts and pants to like figure out where you need to put your arms through, your legs through, putting things on inside and out or upside down, things like that. His writing had become illegible to the point where he wasn't even able to sign his name anymore. Decision-making was poor and he was having trouble finding words, and he developed some personality changes, including irritability and social withdrawal. But again, these personality changes weren't the severe component to his presentation. He required assistance for all instrumental activities of daily living, so those complex things, including finances, managing meds, and some basic things like dressing. I think he also needed sometimes to be prompted to shower at some points, but that's fairly common. In terms of his neurological and neuropsych assessment, he wasn't very spontaneous in his speech, so he didn't really speak unless spoken to. Myoclonus was present in both upper extremities, so like that jerking, muscle jerking that was occurring. He had left-sided limb apraxia, rigidity, and pronator drift. So the limb apraxia being he couldn't make certain gestures like give the peace sign, salute, things like that. Rigidity, just stiffness, and then the pronator drift is you close your eyes, put your palms up, and then you have one hand that kind of drifts back over. So those are indicators of some upper motor neuron issues. He had a positive Babinski sign, which is another indicator of an upper motor neuron disorder. And he had trouble with calculations and left-sided extinction to simultaneous tactile and visual stimuli. So if you presented a finger on the left, he could see it. If you presented on the right, he could see it. But if you presented them both at the same time, he could only see the one on the right. Or see, he would only attended to the one on the right. Neuropsych eval he had global cognitive impairment, but more severe executive and visual spatial problems. Very rare do we find somebody who's unable to perform the trail making test A, which is just basically connect the dots in numerical order, and he could not do this. His spontaneous memory retrieval was low, but his recognition was near perfect, suggesting more sort of dysexecutive aspects of memory impairment than storage or consolidation issues. In terms of his MRI, he showed left greater than right frontal parietal atrophy, left-sided atrophy of the putamen and caudate head, which kind of raises suspicion for something like cortical basal degeneration. His CSF was positive for AD, though. We didn't have any amyloid or tau imaging for him, and he was diagnosed with cortical basal syndrome due to AD. So he was 55. Yeah. Just over, yeah, and then over a year after the initial evaluation, he developed seizures. He cried more often, and he didn't recognize anyone. Yeah, it was incredibly sad. So this is the fifth and final phenotype of Alzheimer's, cortical basal syndrome. Cortical basal syndrome is a type of syndrome that is caused by a lot of different type of pathologies, oftentimes cortical basal degeneration, which is a tauopathy, but can also be due to other tauopathies in the frontal temporal lobar degeneration family. But in this case, it was due to Alzheimer's disease. So a neurological exam is critical when we suspect something like cortical basal syndrome, because it really does come down to a lot of the indications of upper motor neuron disease and those apraxias and things like that that are critical for making a diagnosis here. And just as a note, if someone presents with myoclonus or dressing apraxia, has a younger age of onset, it tends to be more predominant, or it might tend to be Alzheimer's versus cortical basal degeneration. So in summary, early onset AD and atypical variants or phenotypes of AD are heterogeneous. They're also very understudied, but there are a lot of really great large-scale studies that are being done that are trying to understand these atypical phenotypes and early onset AD in a lot more detail, particularly for, well, from my perspective, for improved diagnosis and improved diagnostic accuracy, but also for the benefit of, people going into clinical trials and having a better understanding of what it is that we should be looking for and what kind of outcomes should we be aiming for in these individuals. So just a couple of clinical implications. Treatment and management. Some people might say, well, what does it matter what phenotype you have? It's all Alzheimer's disease. Does it really matter? I would argue that seeing a lot of these individuals and their families, it does matter, because your recommendations for how to intervene and suggestions that you might have for how to support them will differ depending on the phenotype potentially. So you can imagine someone with visual spatial impairment predominant but spared language, and someone with a language predominant impairment but spared visual spatial skills. The suggestions that you have for support are going to be different for those individuals. From a biological standpoint, no, it doesn't matter. But from a quality of life standpoint, for a family and people who are dealing with this disorder, it does matter. So, getting people connected to OT and PT, establishing routines and habits is important. And we always tell people to stay socially, physically, and cognitively active, especially the socially active piece. And then kind of coming to this idea that we had kind of brought up earlier is, in this age of disease-modifying treatments, we don't have a cure for Alzheimer's disease, but we have these couple of medications that are arguably disease-modifying. They do a really excellent job of clearing the amyloid in the brain. There is some evidence that it makes an impact in people's day-to-day lives in terms of their functioning and their ability to sort of looking for maintain independence for longer. But we don't really know how effective these treatments are. We don't really know how effective these treatments are for people with early onset AD or for people who have these atypical phenotypes, because the individuals who were included in the original clinical trials were all late onset with amnestic predominant syndrome. So we don't really know, but we do know that these medications do have different effects depending on people's sort of like genetic predispositions, like ApoE, sex. Men seem to benefit from these medications more than women. So there's a reason that there may potentially be differences of effect across these different phenotypes. And then lastly, we know that there's high risk for certain individuals for the very severe side effects that can occur with these medications, including ARIA-E and ARIA-H, which is the swelling and the hemorrhages that can occur when taking these medications. And so we don't know what the safety is for younger individuals with these phenotypes and things like that. I wish I could talk about caring in EOD. This is my main area of interest. I'm putting together a lab in the Together in Dementia Care lab, currently working on a website. Hopefully that will be coming soon, but maybe that will be a future talk that we can go over. So I just want to leave with this last quote. While no one can change the outcome of dementia or Alzheimer's, with the right support, we can change the journey. So do you think it's really important to recognize these, as esoteric as these phenotypes might seem? I think they can have really impactful implications for families, especially if we're doing a good job of trying to tailor our recommendations and interventions for people. So if you have any interest in learning more about this, publication there has those case studies, and then Leeds had a special issue in Alzheimer's and dementia a couple of years ago that has, it's a whole issue on Leeds data. So yeah, thanks.